The topic of this last presentation is antihyperlipidemics. This topic was supposed to be given in the cardiovascular module. However, because you haven't taken it, we will be discussing it here as the last topic. It is not directly related to the other materials that we have taken in the HLS module. The reference for this presentation in your textbook is chapter 22. So you probably all know that coronary heart disease is the leading cause of death worldwide. That usually involves multiple disorders such as stable or unstable anginas and myocardial infarction, amongst others. And those disorders are associated with a number of risk factors. So what are these risk factors that can lead or increase the risk of coronary heart disease? The main risk factor for having coronary heart disease is older age. Especially this is usually gender dependent, meaning that males are more susceptible for coronary heart disease at a younger age, usually 45 or older, while the onset of coronary heart disease is a little bit delayed in women and happens after 55 years or older. Family history of early or premature coronary heart disease is also a very important risk factor. For example, if a patient has in their family someone who developed a myocardial infarction at a young age, like in 20s or 30s, that's definitely a risk factor to get coronary heart disease. Smoking is definitely one of the most important factors for coronary heart disease, and hypertension or elevated blood pressure higher than 140/90 millimeter mercury is in itself one of the most important risk factors for developing coronary heart disease. Lastly, dyslipidemias or disorders of lipid levels in the blood are also very important risk factor for coronary heart disease. These abnormalities in lipid metabolism can be either as an elevated triglycerides or elevated cholesterol. This lecture will focus on the available therapies that can be used for the treatment of different lipid disorders. Now, to be more specific, which lipid abnormalities or which dyslipidemias are strongly associated with cardiovascular disease? The first lipid disorder is having a very high levels of low density lipoprotein cholesterol. Remember that we have different types of cholesterol, and the low density form is the lipid that is associated with the most risk for developing cardiovascular disease. So this uh, uh, variable here is one of the most important variables that you need to monitor in patients who are at risk for developing myocardial infarction, for example. In addition to that, elevated triglyceride levels are also associated with an increased risk of coronary heart disease. On the other hand, we have other forms of cholesterol that are associated with beneficial effects, and these include the high-density lipoprotein cholesterol. So patients with high HDL levels in their blood usually have a reduced risk. That's why low levels of HDL are usually also associated with coronary heart disease. So to sum up, in order to increase the risk for coronary heart disease, you will have to have a high LDL level, a high triglyceride level, and a low HDL level. All these changes are associated with increased risk for coronary heart disease. So let's take a look at these different types of lipids and what are the major differences between them. Now, remember that lipids in general, or fats, have a low density, right? For example, if you get a glass of water and you fill it with water, and then you add some oil into that, you will notice that the oil will form a layer on top of the water. And the reason behind that is because lipids or fats have a very low density. In the body, because of this low density and because fats and lipids poorly dissolve in water, then their absorption and circulation in the plasma doesn't happen in just the lipid form. On the opposite, lipids are circulate in the plasma and absorbed from the gut and distributed to different tissues in the body in the form of lipoproteins, which are molecules composed of both protein and lipids. And the reason why is that you want to make lipids available to be circulated freely in plasma, and that's why you can coat these fats or these lipids with a coat of proteins. Okay, so the outer layer of a lipoprotein molecule consists of proteins. These are hydrophilic and they allow lipid droplets to circulate in the plasma. Inside the lipoprotein, we will have different types of fats. So we can either have triglycerides or cholesterol. These are the main types of lipids that circulate in the plasma. Now, depending on the content of fat in each lipoprotein, we can divide them based on density into different forms. Remember that the more lipids you have, then the less density the lipoprotein will have. Let me say this one more time. When you have more lipids in the molecule, remember that lipids have a very low density, then the lipoprotein will have a very low density. So high fat, low density. The first type of lipoproteins is a lipoprotein called chylomicron. This is usually the form that is absorbed from the gut after the intake of fat and diet. And chylomicrons consist mainly of triglycerides and a little bit of cholesterol. Okay, that's why they have a very low density. If the fat content, if the triglyceride content in the chylomicron has been decreased on the expense of cholesterol, we call that very low density lipoprotein. So the very low density lipoprotein has less triglyceride content than chylomicrons, but it has more cholesterol content than chylomicrons. And if you keep doing the same thing, if you reduce triglycerides, and increase cholesterol, you will then get intermediate density lipoprotein, and you will eventually have the low density lipoprotein, which contains a very high content of cholesterol. Now, this is the form of lipoproteins that is mostly associated with increased coronary heart disease, especially that it has a very high content of cholesterol. Last thing, the lipoprotein that has the highest density is HDL, which has a very low content of triglycerides and a lower content of cholesterol. And that's why HDL is the healthiest form of lipoproteins, and decreased levels of HDL are associated with coronary heart disease. In order to understand the different disorders that lead to hyperlipidemia and how we can treat them, we need to quickly revise lipid metabolism, lipid absorption, and distribution throughout the body. Remember that you can have hyperlipidemia due to two main reasons. The first is being involved with high dietary intake of fat. People who consume fatty food will definitely develop hyperlipidemia, and that is the form of hyperlipidemia that can be effectively managed through dieting, through exercise, and other lifestyle changes. But we have several disorders that result from genetic abnormalities that lead to elevated lipid levels in the plasma. So let's take a look at those processes. What happens first after someone consumes a meal that contains fat is that fat will reach the small intestine. And in the small intestines, the first step for lipid absorption would be the formation of chylomicrons. Remember that chylomicrons are the least dense forms of lipoproteins. They contain a high content of triglycerides that are surrounded by a layer of proteins. And that allows for chylomicrons to be absorbed into the plasma. Now remember, we don't only get lipids from food. This is one source. The second source for lipids is the lipids that are synthesized in the liver. So yes, liver is involved in lipid metabolism and is responsible for the synthesis and production of different lipid molecules. So at any point of time, in the plasma, you will have chylomicrons that are absorbed from the gut after someone consumes a high-fat diet, and VLDL, or very low-density lipoproteins, that are synthesized by the liver. So we have two sources for lipids in blood. Now, we have a disorder called type 2B mixed hyperlipidemia, and this is a genetic problem that leads to the excessive or the overproduction of VLDL by the liver. This is a very common lipid disorder, and this disorder is effectively treated with lifestyle modifications, with dieting, exercise, in addition to the use of several antihyperlipidemic drugs. In addition to that, we have another disorder called type 4 or familial hypertriglyceridemia. And as the name indicates, this disorder is characterized by high VLDL levels, meaning that the patients will have high triglyceride levels in the plasma, since VLDL contains a very high level of triglycerides. This disorder is caused by the overproduction or the decreased removal of very low density lipoproteins or triglycerides produced by the liver. So we have two main genetic defects that can lead to hyperlipidemias. They're either type 2B hyperlipidemia or mixed hyperlipidemia, characterized by an increased both VLDL and LDL. And we have the type 4 familial hypertriglyceridemia, which is characterized by high triglycerides level, and they are both caused by abnormalities in liver production of lipids. Because type 4 hypertriglyceridemia is characterized by high triglyceride levels, it can be managed with reducing the consumption of high triglyceride containing food, by exercise, and also by using therapies that lower triglyceride levels. Okay, so chylomicrons from the diet and the VLDL produced by the liver can circulate freely in the plasma until they reach adipose tissue, which is the main site of lipid storage. In order to store lipids contained in lipoproteins in the fat tissue, you will need to liberate those triglycerides from the lipoproteins in the form of free fatty acids that can then be stored in the adipose tissue. The enzyme responsible for liberating triglycerides from VLDL and chylomicron molecules is called lipoprotein lipase. So this enzyme is very important in the process of storing fat in the adipose tissue. And that explains why people who consume high fat diet will eventually have high chylomicron levels in the plasma, and then the majority of the triglycerides located in chylomicrons will be stored in the adipose tissue by the action of lipoprotein lipase. So accordingly, patients who have a deficiency in lipoprotein lipase or one of the proteins that activate it, such as apolipoprotein C2, those patients will have a problem in that they won't be able to liberate triglycerides from chylomicrons in the plasma and store them in adipose tissue. This means that high levels of triglycerides will continue to circulate in the plasma. Uh, this condition is called type 1 familial hyperchylomicronemia, and this disorder is characterized by abnormally high levels of chylomicrons in the plasma because you can't degrade them into triglycerides that can be stored in fatty tissues. The treatment of this disorder is mainly by dietary changes. The patients will have to consume low-fat diet. Unfortunately, no drug therapy is effective for the treatment of this genetic lipid disorder. So after chylomicrons and very low density lipoproteins lose their triglyceride content into the adipose tissue, their density will change, right? Because they're losing lipids to be stored in the adipose tissue. So they will be converted from chylomicrons or from VLDL because they're going to lose triglycerides. Their density will increase and they will change into IDL or LDL. Okay, so LDL is then either taken back again into the liver for further metabolism by specialized receptors located on hepatocytes, or it will be taken up by different cells in the body, such as muscles, cardiac muscle. Those are the types of cells that are highly functioning. They undergo heavy metabolism and they would require LDL for energy production and for membrane stability. Remember that cholesterol, it makes a part of the phospholipid bilayer of the plasma membrane of each cell. So it's important. In order for cells to make use of LDL, they have specialized receptors called LDL receptors that recognize LDL and uptake the fat molecule and internalize it inside the cell for metabolism. This means it is very important for these receptors to exist in order to make use of LDL that circulates in the plasma. So the question is, what happens if the patient has a problem in the receptors that are responsible to bind and internalize LDL? This means that LDL will not be able to get inside the cell and it will continue to circulate in the plasma, resulting in elevated LDL level. And in fact, we have a lipid disorder characterized by high levels of LDL in the plasma, and that is called type 2A familial hypercholesterolemia. It's a genetic disorder that is characterized by defects in the LDL receptors located throughout the body. Those patients usually don't have a dietary problem. They consume normal amounts of food, normal amount of fat in their diet. They are mostly slim. They're not overweight. However, they have a problem in internalizing LDL because they don't have the receptor. And that results in high circulating levels of LDL. Remember that high circulating levels of LDL are one of the main risk factors for the development of coronary heart disease. And here we just need to note that one thing is that for every gene or protein in the body, we have two copies, correct? Located in the genetic material. Any gene in the body will have two copies. So since type 2A familial hypercholesterolemia is a genetic disorder characterized by a defect in the gene that encodes for the LDL receptor, you can either have this disorder because of a mutation that happens in one gene, in one copy of the gene that encodes the LDL receptor, and we call that heterozygote familial hypercholesterolemia, or you can lose both copies of the gene that encodes for LDL, and that is called homozygous hypercholesterolemia. In the case of heterozygous hypercholesterolemia, one copy of the gene will be okay, will be functional, and it will continue to produce LDL receptor, although at a lower extent. And in those patients, we can definitely use pharmacological therapy to treat. However, in patients who lack both copies, who have homozygous familial hypercholesterolemia, pharmacological therapy is not effective, and the patient should only rely on diet. So let's start discussing those antihyperlipidemic drugs. Uh, we have several categories of antihyperlipidemics, including statins, fibrates, niacin, amongst others. Remember always that while these drugs are effective in lowering LDL and triglyceride levels in the plasma, they should always be given in combination with strict lifestyle modifications such as dieting and exercising. The first category that we will be discussing are the group of drugs called statins. These drugs are HMG-CoA reductase inhibitors, and they are several drugs in this class. Note that atorvastatin and rosuvastatin, these two drugs are the most potent amongst the other drugs in this group, and they are the most widely used. Simvastatin is used to be the most widely used drug in this group. However, it is associated with some side effects. So let's look at their mechanism of action. These drugs inhibit a very critical step in cholesterol synthesis in hepatic cells. They inhibit the enzyme HMG-CoA reductase, which massively interfere with the de novo cholesterol synthesis in the liver. So it will definitely decrease the amount of cholesterol that is produced by hepatocytes. And that leads to a cascade of events that will eventually lead to internalization of more LDL cholesterol molecules from the plasma, leading to lowered LDL levels. So let's take a look at that in more details. The enzyme HMG-CoA reductase is a very important enzyme that catalyzes the rate-limiting step in cholesterol synthesis in hepatocytes. So you will need this enzyme to convert HMG-CoA into mavulonic acid, which is then converted into cholesterol. This is the cholesterol synthesis pathway in a simplified form. So using statins that can interfere with this step will result in a very low levels of cholesterol inside the cells because you're interfering with cholesterol synthesis. That will reduce the levels of VLDL that are produced by the liver. Okay, and that will also stimulate feedback mechanisms to urge the cells to synthesize more LDL receptors, right? Because of the very low cholesterol levels inside the cell thinks that there is no cholesterol left anymore, and the cell needs to start internalizing more LDL from the plasma. And that's why the cell will start synthesizing LDL receptors more. Remember that LDL receptors can recognize and bind LDL in the plasma and internalize. So this means that the increased synthesis in the LDL receptors that are expressed at the surface of the cell will internalize more and more LDL from the plasma, eventually resulting in lowering LDL level. So statins are very effective in lowering plasma low-density lipoprotein cholesterol levels. However, they can also have other beneficial effects in that they can reduce triglyceride levels in plasma, and they can also increase plasma HDL levels. All are beneficial effects for coronary heart disease. And that's why statins are considered first-line drugs to lower the levels of low-density lipoproteins and to reduce the risk of atherosclerotic cardiovascular disease. Remember that the use of statins have been confirmed to lower the risk of coronary heart disease. This is very important. So who are the patients who should take statins? These are patients who already have an established risk for atherosclerotic coronary vascular disease. In patients who don't have heart disease, but they have a very high levels of LDL of over than 190 milligram per deciliter. Patients who have diabetes, and patients who have a high estimated risk for developing atherosclerotic coronary vascular disease within 10 years. And there are, of course, tools that we can use to estimate that risk. So what are the adverse effects of statins? Statins are heavily metabolized in the liver, and that might be associated with an elevated liver enzymes. So those patients require monitoring of liver enzymes while they are on statin therapy and even prior to that. And most patients who use these drugs usually have elevated levels of ALT and AST liver enzymes and plasma. That means that patients with liver disease who cannot metabolize these drugs will have an accumulation of regular doses that are given to those patients. And that's why these drugs are contraindicated in patients with active liver disease. Another very important adverse effects of statins is that they can be associated with myopathy and rhabdomyolysis, or the disintegration of skeletal muscles. And this is one of the adverse effects that require strict monitoring. Because these drugs are metabolized in the liver, they are also susceptible for drug-drug interactions, and the majority of statins can affect the levels of other drugs that are metabolized in the liver, such as warfarin. These drugs mostly will increase the effects of warfarin and enhance or elevate the INR at a given dose of warfarin. Statins are contraindicated in pregnancy and during lactation. So moving now to another agent that is also used for the treatment of dyslipidemias, and that is the naturally occurring substance niacin, or nicotinic acid. So let's start first by discussing the mechanism of action of niacin. Niacin has the ability to inhibit lipolysis in adipose tissue, meaning that it interferes with the hydrolysis of triglycerides into fatty acids in the adipose tissue, reducing the amount of fatty acids that are secreted in the blood. This means that lower circulating levels of fatty acids, this will reduce the synthesis of triglycerides in the liver, because fatty acids are the precursors for the synthesis of triglycerides. And you know that the liver produces triglycerides in the form of VDL, LDL. And that means also that you will reduce the hepatic output of the VLDL. Remember that eventually VLDL is converted to the low-density lipoprotein. This means that niacin, as it interferes with the hydrolysis of triglycerides to fatty acids in adipose tissue, it will result eventually in lowering the levels of VLDL production by the liver and lowering the levels of LDL that is associated with that. However, note here that while niacin is effective in lowering the levels of LDL cholesterol and triglyceride at estimates of 10 to 20%. Niacin is the strongest antihyperlipidemic drug to increase or cause an increase in the levels of high density lipoprotein cholesterol. So it is the most effective agent for increasing HDL-C. This means that niacin, um, which can of course be used as monotherapy for the treatment of dyslipidemias, is often used in combination with statins because niacin by itself has a weak lowering effect on LDL levels. So niacin is often combined with drugs such as lovastatin and simvastatin. Remember also that the treatment of dyslipidemias or hyperlipidemias can also be combinational, where we use different drugs of different mechanisms of action. Niacin is associated with several adverse effects. The most problematic adverse effect of niacin is that it can be associated with an intense cutaneous rash or flush, an intense skin rash or flush that is associated with warmth and pruritus, meaning itching. So this reaction can be so intense, especially when therapy is first started. And patients are usually recommended to take aspirin or other anti-inflammatory drugs in order to lower the risk of the cutaneous reaction that happens following niacin therapy. Niacin can also cause hepatotoxicity, is metabolized in the liver into nicotinosamide. It can cause chemical hepatitis, so it should be used carefully in patients with liver disease. Predominantly, niacin causes nausea and abdominal pain. In fact, GI disturbances such as nausea, vomiting, abdominal pain are the most common adverse effects of almost all antihyperlipidemics. And because niacin interferes with uric acid secretion in the kidney, it might be associated with hyperuricemia, which can increase the risk for gout or exacerbate gouty attacks in patients who have the disease. Uric acid is excreted in the kidney, and niacin can prevent the secretion of uric acid in the urine. And that results in the accumulation of uric acid levels in blood. And that's why it might exacerbate gouty attacks. Now, moving to another very important class of antihyperlipidemics, which are fibrates, and we have two very important drugs that are widely used. These are called gemfibrozil and fenofibrate. So the mechanism of action of fibrates is very unique, and we need to understand it very clearly to know how these drugs can lower triglyceride levels. In a normal condition, we have a special transcription factor or a nuclear receptor called PPAR or PPAR alpha, which stands for peroxisome proliferator activated receptors. These molecules are nuclear receptors, so they are located in the nucleus. In the unbound form, these nuclear receptors are inactive. So they need to be activated by binding to their ligands. And that's why we call them also ligand-activated transcription factors. The physiological ligands for PPAR alpha are fatty acids and eicosanoids, lipid-based substances. And once these compounds bind to PPAR alpha, this results in the activation of the transcription factor. It becomes an active transcription factor that results in alteration of gene expressions of many genes that are involved in lipid metabolism. Two of those important genes that their expression will be increased include the gene expressing lipoprotein lipase and the gene expressing apolipoprotein C. Remember that increased expression of lipoprotein lipase will reduce the levels of triglycerides in the plasma. Remember that lipoprotein lipase is the enzyme that is responsible for releasing triglycerides from VLDL molecules and chylomicrons circulating in the plasma, and that results in the accumulation of triglycerides fatty acids in the adipose tissue. So when gemfibrozil fenofibrate induce or increase the expression of lipoprotein lipase, you will increase the mobilization of triglycerides into adipose tissue, meaning that their levels in plasma will be lowered. This definitely is helpful for the treatment of hypertriglyceridemias. Accordingly, fibrates are definitely effective in lowering LDL levels and increasing HDL levels. However, their main effect is by massively reducing the levels of triglycerides. And that's why fibrates are mainly used for lipid disorders that are associated with elevated levels of triglycerides in the blood or hypertriglyceridemias. So what are the adverse effects that are associated with fibrates? Of course, they cause mild GI disturbance, similar to all the other antihyperlipidemic drugs. Uh, because they interfere with the cholesterol secretion in bile, these drugs can also increase the risk of gallstone formation. Gallstone formation اللي هو حصاوي المرارة. That's why these drugs should be used with caution or even not used in patients who already have gallbladder disease. In addition, fibrates can result in myositis or inflammation of skeletal muscles. And this is very important because it has been reported that when fibrates are combined with statins, remember that one of the main concerns with statins is that they can cause myalgia, myopathy, and rhabdomyolysis. So if those were combined with fibrates, if they were given at the same time, these drugs can increase the risk of causing muscle disease or rhabdomyolysis, and that can be even um, very problematic in patients with renal disease or renal insufficiency. It is established that the combination of gemfibrozil and simvastatin can massively increase the risk of rhabdomyolysis and myopathy, and that's why this combination is contraindicated. And it's most likely that combining gemfibrozil with any other statin will result in the same thing. So these two families of antihyperlipidemics should not be combined. Fibrates are also metabolized in the liver, and that's why they can cause drug-drug interactions. And similar to statins, they can increase the plasma concentration of warfarin by interfering with its hepatic metabolism. That's why patients who are already on warfarin that will start fibrate therapy should have their INR levels checked frequently and probably will need to lower their warfarin dose. Finally, fibrates should not be given to patients who have established liver disease or chronic kidney disease. Moving to another category of antihyperlipidemics, which are bile acid sequestrants. This family includes several drugs, mainly cholestyramine is the main drug in this family. Colestipol and colisbilem are also other drugs that belong to bile acid sequestrants. So let's now take a look at the mechanism of action of bile acid sequestrants. Remember first that cholesterol is an important component of bile, and it's a precursor for the synthesis of many bile acids and salts. So hepatocytes normally convert cholesterol into several different types of bile acids. Bile acids, along with cholesterol, they make up the bile secreted from the liver through the biliary tract into the small intestine, where bile helps in the absorption of many lipid-based molecules and substances. Bile acid sequestrants have the ability to bind negatively charged bile acids and salts in the small intestine. And this binding is usually a neutralizing binding, meaning that if you have a molecule of bile acid, it will be bound by cholestyramine and the other bile acid sequestrants, resulting in a neutral inactive complex that will be excreted in feces. This means that uh, bile acid sequestrants will result in an increased excretion of bile acids. This will result in lowering their concentration in the gut, and in order to compensate, hepatocytes or liver cells will try to synthesize more bile. And in order to synthesize more bile, you will need to use cholesterol. This means that if you are using more cholesterol that is contained in hepatocytes to synthesize more bile acids, you're going to deplete the intracellular levels of cholesterol. So what do you think that will do, especially for the status of the LDL receptors expressed on the surface of hepatocytes, and then consequently to LDL levels in plasma? Think about this. So again here, just to discuss that over this graph, cholesterol is synthesized or converted to bile salts and acids that are secreted into the small intestines, where they can help in the absorption of lipids, lipid-based substances. Like, for example, we have different lipid-based vitamins such as vitamin D, E, A, and K. These are lipid-based vitamins that require the presence of bile in order to be effectively absorbed from the gut. So bile plays a very important role. You will discuss this further when you take the gastrointestinal system. However, bile acid sequestrants bind bile acids and salts in the gut, convert them into insoluble complexes that are highly increased in feces. This will urge the liver to synthesize more and more bile acids from cholesterol, uh, resulting in intracellular depletion of cholesterol levels. Another class of drugs that also interferes with absorption is the cholesterol absorption inhibitors. And we only have one drug in this category, which is the drug ezetimibe. So ezetimibe directly and selectively inhibit the absorption of dietary and biliary cholesterol. So if you consume a meal that contains high levels of cholesterol, ezetimibe can directly interfere or prevent the absorption of cholesterol from the gut. This will definitely lower the levels of cholesterol that circulate in the plasma. However, the ability of ezetimibe to lower plasma LDL cholesterol levels is modest. It's only about 20% when ezetimibe is used at clinically relevant doses. That's why ezetimibe by itself is not very effective for the treatment of LDL increased levels in plasma. And that's why it's mostly used in combination with statins, especially in patients who have a weak response to statins, so you will need to add another drug to lower LDL, or those who have a very high risk of atherosclerotic coronary vascular disease, where you want to cause a very big reduction in LDL levels. Note here that the combination of ezetimibe with statins has been associated or documented to further increase the risk or the complications associated with atherosclerotic cardiovascular disease. Remember that the combination of statins with niacin will definitely lower LDL levels more. However, it has not been associated with a decreased risk for atherosclerotic coronary vascular disease. Making this distinction between different types of antihyperlipidemics is very, very, very important. Ezetimibe is a safe drug and is usually not associated with many adverse effects. Let's move now to the last family of drugs that can be used for the treatment of hyperlipidemia, which are the PCSK9 inhibitors. There are two drugs that fall into this category, and these are the alirocumab and evolocumab drugs. Both of these are humanized monoclonal antibodies. So in order to understand how these drugs work, let's talk about PCSK9 first. PCSK9 is a liver enzyme. It's present in the majority of hepatocytes in the liver. And its function is that it can bind to LDL receptors expressed on the surface of hepatocytes that are responsible for binding and internalization of LDL molecules inside liver cells. And they can result in the degradation of these LDL receptors. So PCSK9 inhibitors inhibit these enzymes, which means that they will reduce LDL receptors degradation, meaning that more LDL receptors will be available on the surface of liver cells to bind LDL cholesterol circulating in the plasma. So here's a graph presenting that. This is the LDL receptor expressed on the surface of hepatocytes. In the case of, for example, hypercholesterolemia, LDL receptors will bind cholesterol or LDL circulating in the plasma and internalize it inside the cells. Now, PCSK9, as you see here, is an enzyme that binds the LDL receptor and results in its internalization and degradation. So in normal conditions, it lowers the levels of LDL receptors expressed at the surface of the cell, meaning that it lowers the intake of LDL cholesterol from plasma. We don't want that in cases of hypercholesterolemia. We need to increase the internalization of LDL inside the cells. We don't want LDL to be circulating in the plasma. That's why PCSK9 inhibitors, which are monoclonal antibodies, they bind to PCSK9 and prevent its function, allowing more LDL receptors to be present on the surface of hepatocytes, allowing them to bind cholesterol more and internalize it inside the cell. This results in lowering plasma LDL levels. According to the mechanism of action of PCSK9, their main effect is to lower LDL levels in the plasma. And in fact, PCSK9 inhibitors are the most potent antihyperlipidemics to lower LDL levels in the plasma. They're very strong. They're even stronger than statins. And that's why they can be used in combination with statins in patients who have very high levels of LDL, in those who have a very high risk for atherosclerotic coronary vascular disease, or those who have been on statin therapy but did not respond very well to the treatment and still have high levels of LDL. Note here that the combination of PCSK9 inhibitors with statins has proven to further lower the risk of atherosclerotic coronary vascular disease or its complications. This is again very important. Remember that the first line treatment um, of elevated LDL levels of statins, and statins have been shown, it's documented that when they are used, they lower the risk of atherosclerotic coronary vascular disease. If they were combined with cholesterol absorption inhibitors or with the PCSK9 inhibitors, that will result in a further decrease in the risk for atherosclerotic coronary vascular disease. Remember that the combination of statins with niacin is effective in further lowering LDL levels, but there is no evidence that the combination will further lower the risk of atherosclerotic coronary vascular disease. Lastly, PCSK9 inhibitors can also be used in combination with statins to treat familial hypercholesterolemia. PCSK9 inhibitors can be associated with allergic reactions, but because they are humanized monoclonal antibodies, it's unlikely that they will cause severe hypersensitivity reactions. However, they can be associated with an increased risk for respiratory tract infections. Moving now to the last topic in this presentation, which involves talking about omega-3 fatty acids. As you all know, omega-3 fatty acid is there are a group of fatty acids, of polyunsaturated fatty acids that are found in a variety of diets, including tuna and salmon, other types of fish. They are found in fat-rich vegetables such as avocados. They're present in nuts. Uh, they're also definitely present in olive oil. So all these dietary types contain high levels of omega-3 polyunsaturated fatty acids. So omega-3 fatty acids, as we said, exist naturally in different food types, and those two main types of polyunsaturated omega-3 fatty acids are called eicosahexanoic acid and eicosapentaenoic acid. These are two types of polyunsaturated lipids. However, I mean, remember that these are available in various over-the-counter preparations, which you probably heard of, fish oil products, which contain these two types of omega-3 fatty acids. The main effects of omega-3 fatty acids is that they lower triglyceride levels. Okay, so they're very effective in lowering plasma triglycerides. However, there is one problem with them, is that they might also result in a slight or moderate elevation of both LDL cholesterol and HDL cholesterol. And you definitely don't want the patient to take something that will increase their LDL levels. That's why we have therapeutic preparations that overcome this problem, and it's called icosapent ethyl. So this is a drug prescribed by a doctor. It's a prescription drug that is capable of lowering triglyceride levels without the harmful unwanted increase in LDL levels caused by natural omega-3 fatty acids. And the reason behind that is that icosapent ethyl contains only eicosapentaenoic acid, doesn't contain a mixture of omega-3 fatty acids, and that's why it does not elevate the levels of plasma LDL. The main therapeutic use of omega-3 fatty acids, of course, they can be given over the counter, but the main therapeutic level is that they can be used in combination with other antihyperlipidemics with individuals with very high triglyceride levels in plasma of more than 50 milligram per deciliter. Remember that the best drug to use to lower or to treat hypertriglyceridemias are fibrates. So these drugs can be used in combination with. Note here that omega-3 fatty acids can increase the risk of bleeding in patients using antiplatelets such as aspirin or anticoagulants. So they should be used with caution in patients who take these drugs. Just to summarize what we've discussed in this lecture, remember that each one of the antihyperlipidemics will have a different effect on which lipoprotein it will increase or decrease. For example, statins, which are the mainstay treatment for to lower LDL levels or for the treatment of hypercholesterolemia. They're very potent in lowering LDL. They can also increase HDL and lower triglyceride levels, which are definitely beneficial effects. Fibrates are the most potent drugs in lowering triglycerides. Niacin is the most potent drug to increase HDL levels. Note that cholesterol absorption inhibitors are very weak, and that's why they're always used in combination with statins. And note lastly that PCSK9 inhibitors are the most potent drugs in lowering the levels of LDL, and that's why they are used in combination with statins for the treatment of familial hypercholesterolemia or in patients with high risk of atherosclerotic coronary vascular disease. That's why your choice of which antihyperlipidemic to use depends on which lipoprotein or which lipid disorder is the disorder that you're trying to treat. Last note is that we can definitely estimate the risk for atherosclerotic coronary vascular disease. There are multiple tools. This is just the American Heart Association 2013 risk calculator. It includes including factors such as race and gender. Age, of course, is a very important factor in estimating the risk for cardiovascular disease. And in this equation, you will have to insert lab tests for total cholesterol, HDL cholesterol, blood pressure for sure, and etc. Other factors such as diabetes and smoking. And that function will give you that tool will generate an estimated risk of the coronary heart disease in that patient, estimated by 10 years. And based on that, you can decide whether you will want to initiate antihyperlipidemic therapy, statins mainly, or not. Just again to put this all in a clinical perspective, these are the guidelines by the American Heart Association in 2018. Of course, these guidelines change every once in a while as we know more about these drugs and how and their roles in the treatment of acute atherosclerotic coronary vascular disease. Just note, just to remind you, this is just for revision, that patients with atherosclerotic coronary vascular disease must be on statin therapy. Individuals with a very high risk, so they don't have coronary heart disease, but they are at a very high risk, will have a threshold of 70 milligram per deciliter LDL. If they go above that, you will have to start statin therapy. Patients who have familial hypercholesterolemia will definitely require statin therapy. Remember, there was a slide that shows you the main indications for the use of statins. So please take a look at these guidelines on how statins are given, when they should be given, and when they should be given in combination with other antihyperlipidemics. Thank you all for listening to this presentation. If you have any questions, please don't hesitate to contact me via email or on Microsoft Teams.